Warm welcome on behalf of Association of Community Ophthalmologists of India in the special Acoin session, the 81st annual conference of All India Ophthalmic Society here in Kochi 2023. We are going to start the session. So may I request Dr. Lakesh Madharia, our national president, to chair this session. And Dr. Lakesh Madharia is from Bilaspur, Chhattisgarh. I'd like to call upon and invite with profound regards Professor Lolit Nepalia sir. Professor Lolit, please to come and to co-chair the session. Professor Lolit Nepalia is our Vice President of Acoin, as well as the retired Professor in HOD Ophthalmology, Government Medical College, Ajmer. I'd like to call upon Professor Praveen Basist of RP Center, is here, to be the moderator. At the same time, I would like to call upon the expert commentators of this particular session. Professor K. Mohadevan sir, please come on the dais. Professor K. Mohadevan sir is the retired director of Regional Institute of Ophthalmology, Trivandrum, Kerala. Right now he is the professor and head of the Department of Ophthalmology, Gokulam Medical College. Dr. Harsha Bhattacharya is here. Professor Khurana, Professor Dhul, Professor Subramaniam Malla. Though they are not within the list, please be kind enough to take the burden, and I would like to request Professor G.S. Das sir, Gunasagar Das sir, please come over the dais and to be one of the expert commentator. Professor Gunasagar Das was the retired Dean as well as Professor and Head of the Department of Ophthalmology of VSS Medical College, Sambalpur, Burla. I'd like to call upon our young, energetic Joint Secretary of Association of Community Ophthalmologists of India, nobody else than Dr. Indar Mohan Rustogi sir from Haryana, to come over the dais and to be one of the discussants. Heartiest welcome to ever dynamic Dr. Shatangshu Mathur, our convener, to be here. Dr. Shatangshu Mathur is the Chairman Scientific Committee of Acoin. I'd like to request each one of you who are in the rear seats, please come forward, and like to hand over the mic to Dr. Shatangshu Mathur sir to start this session. And before that, he will give some introductory address. May I call upon Professor Praveen Basist, who has just come over, to come over the podium and take the dais. You all know Professor Praveen Basist, who is the chairman of our academic and research committee of Acoin, as well as he is the chief in charge of community ophthalmology department of Rajendra Prasad Center for Ophthalmic Science and AIMS, New Delhi. So I like to hand over the mic to Dr. Shatangshu Mathur sir to give his welcome address and to start the session as a convener.
Thank you, Dada. So we are going to start without wasting time our session. And first speaker, Dr. Subodhi is not here. So we request Dr. Ajay Agarwal. And Purban Ganguly is here? No. Santosh Kashyap is here? No. Inda Mohan Rastogi is here. So next talk will be Dr. Inda Mohan Rastogi. नहीं बोले चलो discussion ठीक है सर. Ajay Agarwal will be speaking on integrated people centered eye care for technical blindness due to glaucoma. LC Madharia sir and I is here. Next is yours.
Okay. Good morning to the panel on the dais and off the dais. And thank you, Dada, for including me in your session. So I shall be talking about integrated people-centered eye care for tackling blindness due to glaucoma. But before that, I have no financial or proprietary interests. So this is the outline I shall be talking upon. And we all know that a large percentage of people, 2.2 billion people, have some sort of visual impairment. And half of those have impairment which can be prevented. Out of this, 76 to 80 million people are living with glaucoma, which is a very big percentage. And more than 75% of the visual impairment is avoidable, which is blindness, which could either be treated or prevented by known cost effective means. So, glaucoma is the second leading cause of blindness and the third leading cause of visual impairment worldwide. So it is projected that by the year 2030, there would be 95 million people with glaucoma. And as of now, 3.2 million people are blind due to glaucoma. So we talk about cataract all the time, but Andre Marmud has said then when you look at 1 million people, you will have 10,000 cataracts every year. And at the same time, you will have 10 to 20,000 who will have chronic glaucoma as well. Out of the total 76 million worldwide, Asia, there are 45 million. And if you look at China and India together for almost half of the visual impairment. So, worldwide, one fifth of the global burden of glaucoma is in India, with an almost equal proportion of closed angle and angle closure glaucoma. And as per the largest study, in the urban population, about 2.1% had open angle glaucoma and about 1% had primary angle closure glaucoma. Similar figures in the rural population as well. So, when you talk about integrated eye care, it means that you include all aspects of healthcare, not only curative, but promotive, preventive, and rehabilitative for all eye conditions, incorporating eye care in the national planning and policies, and bringing eye care to the people. So, when we talk about IPEC, what is people centered eye care? So, it is services which focus on the needs of the individuals. They ensure that the people's preferences are taken into account, and they provide care which is respectful and responsive to the people. And it is about what matters to you rather than what matters with you. So, why do we need integrated eye care? That is for planning and financing our health resources to improve health outcomes, the quality of care, and the patient experience. Because in the end, what will matter is if there is good eye health, there is good health and well being, quality education, and economic growth. And all of this is linked with gender equality and the reduction of the poverty of the country. So, how do we put this into practice? Through health literacy, by prioritizing primary and community care services, coordinating eye care services with other health services, and inclusion of the eye care into the health plans and policies. So, one of a very good model is the LV Prasad Eye Institute model, where you have vision centers, where you have other centers. So, at the basic level, it is the people amongst the population who are responsible for screening out those individuals who have some problem. They report to the vision centers where refraction is done, a basic evaluation, so you can screen for glaucoma there, and then they are referred to the other specialized centers. So that is how it works. And what is the first thing that you should advise to the public is plan for an eye examination. Ask them to look around in the family for those who are vulnerable, get them screened for glaucoma. And so herein lies the role of the vision health guardians and the vision care centers. So early screening and detection is the first step in preserving vision. And for this, the integration of the eye care services with the primary health care is fundamental. So you should advise a regular eye examination, systemic parameters, extremely important, control of weight, diabetes, and hypertension, wearing eye protection, avoiding excessive caffeine and smoking, vigorous weight lifting, certain postures like Shirshasana, which can increase the intraocular pressure. So the take home message is that everyone is at a risk for glaucoma. There may be no warning symptoms. So you need to integrate screening as part of the NPCB VI, because early screening and detection is the first and the most vital step which will help in preserving our vision. So I thank you for a patient hearing.
Dr. Agarwal, you have very rightly highlighted points related to glaucoma, which is a silent killer. I always keep telling on various platforms that not only the public, even we doctors should be aware of this problem. We neglect ourselves to regular checkup and getting glaucoma ruled out. And I think you have a point which you have raised to follow the LV Prasad model. That's a wonderful idea. And I would request Dada and all other dignitaries to take into account as to hold as many as glaucoma screening camps and awareness camp as possible to really get rid of this sight-threatening disease, glaucoma. Thank you once again, Dr. Agarwal. Now I call upon Dr. Madharia for his presentation on diabetic retinopathy.
Yeah, thank you, sir. As Professor Nepalia sir has told, during the last 1 year, Dada and our team of Acoin, we are doing the Drishti program of every district. And during that, as I am talking, I belongs to Chhattisgarh and Bilaspur district. In our Bilaspur, at least 15 districts we have covered. We are going to the village site. We are doing the screening of cataract, glaucoma. We have already started. And we are going to the school also. So this program, Acoin has already started. And really, Dr. Agarwal has given a very nice presentation. Thank you for that. Now, I will start my presentation.
I would request Dada to take an account of a note made by him that all these activities of Acoin should be highlighted on the platform of AIOS in any form, whether it's a soft copy or a hard copy or whatever it is, because as I have already mentioned, awareness amongst ourselves is of paramount importance.
Respected Professor Nepalia sir, Dr. Mahadevan sir, Dr. Das, and our secretary, Professor Samanta sir, and off the dais, all the Acoinian. As we all know, one of the important, as Dr. Agarwal has recently very nicely pointed out and has discussed, the silent killer of our sight, the thief of our sight is glaucoma. And the next important cause of blindness is the diabetes. As we all know, India has become the diabetic capital, and presently about 8 million 7 to 8 crores people, they are suffering from the diabetes. And because of the lack of the awareness, many people, they become the blind. As glaucoma is a preventable disease, up to some extent, as we all know, this diabetes blindness can also be prevented. So I am going through a short, though this is a very long topic, so we can understand the diabetes. What is the diabetes? As we all know, diabetes is a chronic disorder characterized by persistent hyperglycemia, presenting with varied manifestations and consequently resulting into micro and macrovascular complications. Epidemiology of the diabetic mellitus. This is a presentation as we are seeing in the world in 2000 the total number of diabetic patients were 171 million, and it is projected in 2030 that it will be reaching to the 366 million. In India, in the 2000, it was 31 million, and in 2030, it is projected to be the 79 million. So India has become the diabetic capital of the world, and it will remain for 30 years. Now, as we all know, India has become the most maximum population of the world. We have crossed the China. This is not a good thing, but we have to face all the problems. This is a different configuration shows in the world map. According to the International Diabetic Federation in Europe, in 2015 it was 59.8 million, and by 2040 it was projected to be 71 million. In the Middle East and North Africa, in 2015 it was 78.3 million, and by 2040 it is projected to be 140 million. In Africa, again the same thing, it is increasing. According to the International Federation, 415 adults are having by 2040, more than 640 million of us will be living with the diabetes. 50% of all diabetic patients live in maximum in the China, 98.4 million, then comes the India, then comes the USA. These are the different configurations showing that 12% of the global health expenditure is spent on diabetes, and by 2040 one adult will be suffering from the out of 10 one will be suffering from the diabetes. So this epidemic, it has become almost taken a shape of epidemic, we can say roughly. So incidence of diabetes in India, it is due to lack of exercise, genetic determination, and morbidity increases due to low level of education and poor awareness, as we see in the rural area. So this is another very important thing, is dangerous pre-diabetic zone. Diabetes patients having fasting blood sugar more than 126, and this is so the normally we consider the fasting blood sugar 100 to 110 milligram. But if it is more than 126, then he should be considered as a pre-diabetic. The diabetic patients presently is 62.4 million, and pre-diabetic is almost more than that, 77.2 million. So if awareness will not be created, then these pre-diabetic borderline patients of 77.2 million will jump into the diabetic patients. So this will be a very dangerous position. As we all know, very poor awareness of the diabetes. 25% of the urban population, to whom we say they are the intelligent people living in the city, 25% of them, they are not aware of the problems of the diabetic mellitus, the complications of diabetic mellitus. 12% of diabetic patients are aware about it, only the 12% is aware of its complication, and 40% of diabetic patients were aware of its causes the organ damage. WHO divides this diabetic into two types. We are not going to detail of it, as we all know it. Then the prevalence of diabetes in the different states of India, it varies from 0.5 to 28%. So it is very much high, much in some of the state it is in 28%. Can a diabetes affect our eyes? blurring of that we all know, the cataract, then the glaucoma, the incidence of glaucoma increases in the diabetes. The neovascular glaucoma, this is a very dangerous glaucoma due to complication of neovascularization of the iris. So the early diagnosis is a must, and patient may lose vision in a week or sometime less than a week when he developed the neovascular glaucoma. Then this is the most important thing we know. The cause of blindness is the diabetic retinopathy. The longer the duration, more the diabetic retinopathy. So this is the duration. If it is a duration of the 5 years in type 1 diabetes, 23% develop diabetic retinopathy. If it is the duration of 10 years, then the chances increases to almost 80%. And after the 20 years of the diabetes, almost the 50% they have lost their vision due to the diabetic retinopathy. And type 2 diabetes, lower rate of complication because they develop diabetes in late phase. Diabetic retinopathy in late phase. Investigation by direct fundoscopy, indirect ophthalmoscopy, and examination by 90D. During our district program of Dada, we visited 2 villages, so many villages in every district. There we did the blood sugar testing also, along with the ocular examination of these diabetic patients. So we find the villagers, they don't bother for the control of diabetes. What they say, आई एम टेकिंग टेबलेट, बोले हम तो साहब वो दवाई जो डॉक्टर साहब लिख दिए हैं पीएससी वाले उसको खाते हैं बस. दिस इज द दे थिंक वॉट एवर टेबलेट दे आर टेकिंग इट इज कंट्रोलिंग द डायबिटीज, बट वी नो इट इज नॉट ट्रूथ. These are the by OCT examination of the diabetic patient. This factor for diabetic retinopathy. Diabetic is a leading cause of blindness in Western country. Relationship of diabetic retinopathy and HbA1c. This is a very important parameter for developing the diabetic retinopathy. According to the DCCT, Diabetic Control and Complication Trial in Type 1 Diabetes, the tight control, very strict control of HbA1c, 7.2 versus 9%. The comparison was done. 76% reduction in retinopathy. If the HbA1c is well controlled, so definitely the diabetic retinopathy incidences reduces. 60% reduction in neuropathy, 54% reduction in nephropathy. According to the UK prospective diabetic study, type 2 diabetes demonstrated that the tight control of HbA1c, 7% versus 7.9%, was associated with 25% reduction in microvascular diseases, and strict control of blood pressure, 144/82 versus 155 by 90, result in 32% reduction in diabetic related death. So strict control of diabetes has got a very important role. Other factors modify the risk of diabetic retinopathy. As we have already discussed this duration of diabetes, it is then the control of blood sugar by Diabetic Control and Complication Trial of UK prospective diabetic study, intensive treatment of diabetic retinopathy, delay onset of the diabetic retinopathy. If it is well controlled, delays the progression of diabetic retinopathy. The different types of the diabetes retinopathy. The proliferative diabetic retinopathy is more prevalent in type 1 than the type 2. Macular edema develops in 20.1% in younger onset group, 25.4% in older onset group, and 13.9% older onset in non-insulin dependent group. Then other factors which modifies the risk of diabetic retinopathy, nephropathy, it increases the risk. Then hypertension, as we have just discussed, better the control, the progression of retinopathy is very slow. Pregnancy, it is significantly associated with progression. Then the genetic factor, this is very, very important. So persons, those who are suffering from, their parents are suffering from diabetes, there should be more awareness regarding detection of the diabetes, and if it is detected, then the every 6 months checkup he should be done. The factors reducing the prevalence and severity of diabetic retinopathy causes asymmetrical diabetic retinopathy. One eye and the other eye, both eye, there will be different. This in case of glaucoma, we get it. In case of myopia, in case of carotid artery stenosis, in case of retinochoroidal scarring, due to these are the reasons when there will be asymmetry in the diabetic retinopathy of both the eyes. The clinical feature, non-proliferative diabetic retinopathy, we are not going into detail of it. As we all know, it could be mild, moderate, severe, and very severe. Then the classification of diabetic retinopathy, mild NPDR, moderate NPDR, we all know it's this is the color and the angiography. Then the complication of next is the severe NPDR and very severe NPDR. This is a photograph of severe non-proliferative diabetic retinopathy. Classification of the proliferative retinopathy. These are the different features we see. So these are the different photographs of. So in this is the NPDR with succinate retinopathy. This is the proliferative with the CSAME. This is the mild case. This is the diabetic maculopathy. Diabetic maculopathy is a very severe case. These are the different diabetic maculopathy. The ETDRS classification may not be easy to follow the routine. We have taken the International Clinical Diabetic Macular Edema. The diabetic macular edema may be either absent or present. Then the diabetic maculopathy, it could be mild, moderate, severe, and ischemic maculopathy. This is very important because if we are able to diagnose the ischemic maculopathy, the prognosis we can explain to the patients. For prognostic point of view, this is very important. These are the different photographs of OCT. So these are the different OCT pictures of different type of diabetes. Now this is the OCT classification of the macular edema, because OCT is always present in every general ophthalmologist also. So sponge-like retina looks like, then the cystoid macular edema, then the serous retinal detachment we can see in many patients, then the traction macular edema. This is OCT examination is very important, because if the traction in the macula has developed, then all the treatment, even after giving the anti-VEGF, patient is not going to improve. And so it should be, patient should be explained, medical therapy will not help you. You should go for the surgical therapy. So then last is the taut posterior hyaloid membrane. This is another indication for the early vitrectomy. So what is the guideline for general practitioner? Always stress on the duration of diabetes. If the diabetic duration is increasing, then the likelihood of increasing the diabetic retinopathy is more. Second, control of HbA1c and hypertension. It is very important. We see many patients. As one of my patients, he is having diabetic since last 20 years. But up till now, he has not developed the diabetic retinopathy. It is strictly controlled and regular eye checkup. Regular eye checkup every 6 months. Then the renal compromised patients, so those who are suffering from the renal problem, the severity increases very fast. So the strict control of diabetics is very important, and every 6 month checkup is very important. So this is the take home message for all the general ophthalmologists. So all the diabetic patients should be seriously warned about its complication and the regular eye checkup and strict control of the diabetes, along with the other parameters should be normal. So with that, a good diabetic control, we can enjoy the excellent vision. Thank you very much for patient hearing.
Thank you very much.
Sir. Sir. Sir.
So all diabetic patients in the diabetic clinics,
Right.
the main problem in the diabetic patient don't refer diabetic patients.
Right.
That's the problem.
Yeah. We
Such a situation,
sir.
in a diabetic clinic,
Right.
if they are dilated and do a smartphone technique,
Sir.
Can you go to the mic?
Please, sir, mic is there.
There's
Sir.
a mic there.
Please introduce yourself first of all.
the
Yeah.
main problem in diabetic retinopathy is not getting patients to Aioc. Diabetic patients don't refer diabetic patient for eye checkup.
Right.
That's the problem.
Right.
So what I suggest is in a diabetic clinic only, if the smartphone technique is used, then you can know the condition of retina of diabetic patients
Right.
and advise them properly.
Right. In
The telemedicine coming over.
in one of the program of our Acoin, sir, we are having a CME program for prevention of diabetic blindness, meeting along with the physicians, ophthalmologist physician. So in every district we have organized a meeting in the IMA, under the banner of IMA and Acoin, the meeting of ophthalmologists and the physicians, because the diabetic patient, they first come to the physicians. So physician has to be more aware, because as I have told, 40% people, they are not aware the complication of diabetes. They think जैसे मलेरिया हो गया, 2 गोली खाएंगे ठीक हो जाएगा, वैसे वो सोचते हैं कि हम डायोनिल लेते रहेंगे हमारा बढ़िया चलेगा. They are not aware of it. Many young patients they came. So we are having a meeting of Acoin regarding the awareness for along with the physicians. So physicians is the first person to see the diabetic patients.
In Mysore, what happened in Mysore Medical College? 1 minute. About 45 years back,
It's not the question of general vision.
10 medicine units are there.
It's very
10 ophthalmoscope was supplied. It was not used for a period of 40 years. Then it was shifted to eye department. And in government primary health centers throughout India, more than 10,000 ophthalmoscopes are lying waste.
I think your points are well taken up.
Ophthalmic assistants, whereas physicians are there in taluka hospitals.
Quite.
They don't have ophthalmoscope.
Thank you.
Actually, sir, the
Vision is not trained basically. At present, vision is not
Thank
trained.
you.
Present that people do ophthalmoscopy. The question is, it's not a question of vision. I have seen that the dermatology, it's an era of subspecialty in the vision. The diabetic patient will go to a dermatologist. He will not go to general vision at present. You have a nephrologist, you have a cardiologist, you have a gastroenterologist. The problem is that what I have seen, that the diabetologist, the number of the diabetes is so much that he sees a patient in 5 minutes, he doesn't refer to the patient, diabetologist, not the patient. An expert on diabetes doesn't refer the patient in time to an ophthalmologist.
yeah.
And when I see, I tell him, have you done a HbA1c? Didn't your dermatologist told you? He says, no. One patient I noticed, HbA1c was 17.
I have made a routine.
Thank you, sir.
I have made a routine. Yeah. Any diabetic patient coming to my clinic, I get it checked his blood sugar, fasting, PP, and HbA1c and lipid profile. That everything I see. Thank you very much.
Thank you, Dr. Madharia, for your wonderful, meticulous presentation on a disease like diabetes, which you have rightly mentioned. There's a tremendous rise in diabetic population world over, and we in India are perhaps more at risk compared to our neighbor countries or other countries in the world. So we have to be very careful about this upcoming problem of diabetes in Indian population. You have very rightly highlighted the epidemiology of diabetes in India and abroad. You have very rightly mentioned the complications of, various clinical presentations of diabetic retinopathy, the complications, how to overcome, and your take-home message was very meticulous. I agree with all the points you have highlighted, and I again congratulate you for your wonderful presentation. Thank you, Dr. Madharia.
Thank you, sir. Thank you
Over
very
to
much.
Dada.
In this fine morning, let me take the privilege to tell only for a couple of minutes.
Thank you, sir.
I like to quote from
As Professor Nepalia sir is having a flight, so thank you, sir. Thank you for coming and thank you for chairing
My
the
pleasure,
session.
sir. I thank all the stalwarts of Acoin to give me a chance to be here on the platform and share some of my views with you. And it's always a pleasure to interact with Dada, and
all best wishes for the future of our Acoin. Thank
Okay,
you
sir.
all.
See you in National Conference at Bilaspur, sir.
Thank you. To quote from the beautiful lines of Tagore, when he has instituted Vishwabharati Shantiniketan, the university for the universe, that place would be a place which will give us Atvar Ananda Praner Aram. That means the pleasure in my heart as well as the happiness in my life. Community ophthalmology is like that. Just to recall my early days when I started my postgraduate thesis work on ocular leprosy, I got the late line from Mahatma Gandhi that leprosy will never give you money but will give you some pleasure in your life. So also at the flag end, this community ophthalmology. What Dr. Madharia has told beautifully on these lines of diabetic retinopathy awareness, to make the people aware, especially the diabetics, to take their eyes, to take the advantage of the general physician, to take the physician of other doctors who are treating diabetes. But to me, that is far away to ask the doctors, why should we not go to the philanthropist? The philanthropists are the best person to guide the community to seek advice. This morning I had been to a church in Kochi in a mass Sunday prayer. What I saw, more than 1,000 people are hearing the words of the pastor, and the pastor is going on to the lines of Bible. And what is astonishing me, that the dialect of Bible is just like chanting mantra of Hindus, and that is interesting to hear. And you know, whether in a church after mass congregation or in a mosque after this prayer on Friday, the pastor or the Maulavi used to tell something about the society and others. And all the disciples, they like to hear and they like to carry on these words. So if we can convince this pastor or these Maulavis to tell a few lines on diabetic blindness, that will be great help to make them aware. And at the same time, if each and every ophthalmologist, I have seen so many doctors are there in the mass, so they can examine at least 50 diabetics within the mass in search of diabetic retinopathy, some of our task would be done. In that way, we have to propagate the message. Thank you very much.
Thank you, sir. Thank you. As we are having the next speaker, Madam Subhadra, Madam, your things are ready, na, Madam? So I request Madam Subhadra Jalani, Madam, to come and deliver his lecture on the initiative in universal newborn eye care in India and Southeast Asian region. As we all know, Madam is a renowned VR surgeon of LV Prasad and a specialist in ROP, and she is very much keen in this subject, and she is authority of ROP in India. So I will request Madam Jalali, Madam, to deliver his lecture. Thank you.
Thank you so much. Thanks to Acoin to give me this opportunity. So a lot of you have heard me speaking about ROP. So today I'm not going to speak of ROP. I'm going to speak of something very more important. So you know, India produces 23 million children every year, and we have the highest amount of childhood blindness. And a lot of this is because there is no proper program to screen for eye health at birth. When the newborn baby is born, they will screen for heart. Every baby will have a stethoscope put on heart to check is there heart problem, but nobody is even opening the eyes. And we are a very in very shameful condition that congenital cataract children are studying in blind schools. You know, when congenital cataract is so much treatable, that's just one tip of the iceberg. There are so many other conditions. So we have been talking many times to UNICEF, WHO, neonatologists, so many years, 20 years. I am talking about it. Whenever I talk about ROP to neonatologists, I also talk about universal newborn eye screening, at least a basic newborn eye screening. So we are very proud and happy that WHO has finally put in their toolkit for newborn screening. Newborn baby screening, they have already few conditions, and now they have put eye checkup of newborn babies as a very important part. So now it is coming from the neonatologist. So always we are pushing it should come from them. So finally we have reached that level that it has come from there. And WHO head office, they requested me to make a video for the healthcare workers. They said we have some videos, but they're all done in very high-end hospitals. So our health workers are not able to connect to it, so it doesn't seem that they will be able to do this. So can you do a video with your routine health workers? And that is where I think it's for the community, that can community health worker at least do a basic eye checkup of newborn babies and what should be the parameters and all. And then I have sent them the video, and then they have accepted it. They have distributed to all the countries. We are very proud of that. And now the Southeast Asian region head office of WHO, they have taken it up in a big way. So we had a big meeting on the web with all the Southeast Asian neonatologists, and myself, Anand Vinekar and Parijat Chandra from Narayan Netralaya and from All India Institute, RP Center. We were there for the meeting, and we have explained to those newborn eye specialists, doctors and nurses, how they have to go about it. Then they have requested us some things to give, especially they wanted some pictures, and they wanted us to tell them how will the health worker triage these babies. So if they see something, how do they know it is emergency or not emergency, and when it has to be sent. So we have sent them a document. I'm just sharing with you, and maybe if there is some input you can give. You are all on the field, you are seeing so many things. Maybe we are only 2-3 people who have given this thing, but if there's any input, please feel free. In that group, PGI pediatricians were also there, and other people from Indonesia, China, Nepal, Sri Lanka, so many countries they were there, Vietnam, Cambodia. So it's going to be for whole of Southeast Asia. So this we have just written this for the healthcare worker, that this is what an external eye will look like. So the eye has internal and external parts and some adnexa, and the very simple diagram with simple words that this is what are the parts of the eye. And then that there's also something called adnexa around, so they should be aware about the orbit, the lacrimal gland, eyelashes, and tear area. So just these 5, 6, 7, 8 points which a health worker can see with a torch. Without trying to look inside the eye. And then of course it shows that what is the outer part of the eye, again in a live eye, external parts of the eye, which you can see with the torch. Just by opening the eyelid of a baby with the torch, you should see these parts of the eye clearly. And if you have to see the retina, then you cannot see it. You have to either send it to a specialist if you suspect something, or maybe in future we will get some better handheld cameras which anybody can use. So already I saw, again I have been talking to many companies about this. I don't know if you had time to see. Welch-Allyn has already come up with camera on direct ophthalmoscope.
Oh, good.
So direct ophthalmoscope, now you don't have to go and see. Right. You can just click a picture on the direct ophthalmoscope, camera is there. So it will just take a picture. So your residents, fellows, neurologists, eye specialists can also do that. And after seeing that now, Keeler and Heine also said we will see to make it better. Walk also on. So I think direct ophthalmoscope, if it has a camera, it will be so much more useful for so many things, not only for children. So this is what we are trying to show the health worker, that this is how a normal baby's eye should look like at 6 weeks. They should have central steady maintained fixation, and there should be curiosity on their face when they look at you, and they want to see everything, so they'll keep their eyes wide open, and they will try to follow something. But if they have serious eye problem, then we don't have to wait for 6 weeks. But at birth, we should do one screening. But this is just to say that this is how a normal child should look at 6 weeks. So we said that you have to do a torchlight examination and a red glow. 2 tests, a simple torchlight and red glow. And if the red glow fails or the torchlight fails, then you send it to the eye specialist. So if there is any infection, secretion from the eyeballs are looking red, congested, then this could be viral or it could be ophthalmia neonatorum, refer. And this is emergency. And again, this is emergency, same day referral, urgently to eye specialist if there is a change in color of the eye, or if you see any red color, yellow color, white color, or swelling around the eyes, or the patient is not opening the eyes or is in pain, then you send. So again, if there is exposure of the eyeball, the lids are not closing, or you see some white area on the black part of the eye, or there's thick discharge and patient is not opening eyes, these are emergencies, send on the same day. And then again, this is sent on the same day or within 1 or 2 days, where there is loss of transparency or there is watering, redness, or child is looking that it's not looking at something, and there is pain. If the child is pain or not feeding, and then you see some redness, then send on the same day. And this one is semi-emergency. These are not emergencies. It is better to send within a week or 2 weeks, because if you say go after 1 month, then they will not go. So we have to just put emergency and non-emergency or semi-emergency. So here we have said try to send within a week if the eyes look white or the transparency is not there, or you find that there is an ophthalmia, there is no eyeball, or the child has ptosis, or the pupil doesn't look round, it looks oval, then these patients need more examination. So this we can send within 2 to 4 weeks. You can book an appointment and then send. There's no emergency about it, but they should send. Again, this is semi-emergency if there's a failed red reflex. Red reflex is lost, and in the video we are showing how to do this red reflex test. And if there's a white reflex, then they need to be seen. These are serious eye problems. So again, these are semi-emergencies, and within a week, if you find white reflex, which is of course of the cataract or retinoblastoma, whenever they see a white reflex, they should send. So if there is anything unusual about the eyes, the baby is not opening eyes, or one eye is looking smaller than normal, or the child is squinting, and so we know, all of us have experienced that when they squint, they tell them that go after 1 year or 4 years. So that is not the correct approach. Approach is, if there is a squint, child should be seen within 2 to 4 weeks and not wait. And of course, if any child has eye pressing behavior, most of these are retina problems, LCA, ROP, FEVR. If you find child is pressing their eyes, then this is eye problem and you should send to eye specialist. Then again, if the eyes look small, big, difference in size of 2 eyes, then you should send within a week. And if one eye suddenly becomes larger than the other, when it was not so at birth, or you find that there's one eye is protruding outwards, then also this should be sent quickly. And then if anybody in the family had eye problem, like this family we had, the youngest child was brought to our hospital by a health worker, community health worker. The other 3 older children, you can see how old they are, they were all in blind school. So one after the other, the children are going to blind school and nobody is taking them to an eye checkup. This is the story in our rural areas. So this is what we are telling health workers. If any child in the family had eye problem, then the next child should be sent at birth to the eye doctor. Same way, retinoblastoma. The mother had eye removal done. Nobody told her that your child needs eye checkup. And then there are other family history of eye problems. And for ROP also, we have just put one line, because this is for health workers, that if there is a preterm baby, then please send for detailed eye checkup at 30 days of birth, because they can get blind. Then if children have been born with any skin problems, especially this incontinence pigmentosa, but any skin problems, like they can have herpes, they can have erythromonoidosum, or they can have this incontinence pigmentosa. So if there is a generalized skin disease, then also these children should go for detailed eye checkup. So at every visit, so this is at birth, and then after that, at every visit, 3 questions the health worker should ask, look and test, ALT. Ask, do you think the child has any problem in the eye or vision? This should be asked to the mother, because mothers notice eye problem very early, before anybody else. So this question should be asked, do you feel that your child is looking okay? Does he have any problem? And do you think the eyes are looking normal, or is there any abnormal eye movement or shaking? And then with the torch, you should check the baby whether it is following the light or toys or not. And of course, then we already have this in our national guidelines. It's not implemented on the ground. So we hope that this initiative by pediatricians will help us to investigate. Do we have 2 minutes?
Yeah.
More? So I'll show the video which we have prepared. This is available on YouTube. All of you can download it. So can we have the sound? Yeah. The eye health screening is a crucial component of the overall health assessment of every newborn. Soon after the baby is born, the health worker attending the baby should screen the baby's eyes along with the other health checkups. The follow-ups are also equally important and should be done at every subsequent health check visit. The same test to be done again and again at every checkup. This video is going to demonstrate 2 relatively easy eye tests that can be performed on the newborns by any health worker or even a family member. And if any abnormality is detected during these tests, then the infant should be seen by an eye specialist at the earliest. But hygiene first. The hand sanitizers alone are not sufficient to eradicate viruses from hands. Hence, the eye examination should be done only after thoroughly washing the hands with soap and water and then drying them appropriately. This should be repeated both before and after checking each baby's eyes. Unclean hands or wet hands will spread infection from one eye of the baby to the other baby. Also ensure that the examiner doing the examination does not have long nails that can injure the eye. Always remember to dry your hands after using hand sanitizers, as these should never come in contact with the eyes. So let's get going. The first test is a simple torchlight examination. Gently open the eyelids apart without pressing on the eyebrow or the bone region, and do this in a child when they are happy and well fed and they are not crying and cranky. Check one eye at a time, and when you want to compare both eyes, then open them simultaneously. The parts of the eye that will be visible are the eyelids, the surrounding area including the lacrimal sac area, the conjunctiva, which is the outer covering of the eye, the cornea, that is the front transparent part of the eye, and the front part of the eye behind the cornea called anterior chamber. The pupil, as all of you know, is in the center of the eye, and then the iris is the colored part of the eye, which is often blue or brown and which gives the color to the eye, and then the lens, which is a transparent layer behind the pupil. Now, what do we want to look for? We want to look for the size of each eye. Are they equal? Are they normal looking? Is one eye smaller or bigger? Then we check the lacrimal sac. Usually children who have lacrimal sac problem will get discharge, watering from the eyes, but you can check for it by gently pressing the inner corner between the lids and the nose as shown in this video, and look out if there is any pus or mucus coming out from the underlying lacrimal sac around the eye. If there is any difference in the appearance of the eye, or there is defect in the eyelids or swelling around the eyes, or any discharge, redness, transparency of the cornea is lost, or the clarity of anterior chamber is not there, or the shape and color of the iris or pupil, then these are abnormal. Normal pupil should be round and central, and the center of the pupil should be transparent, and the color of the iris should be same in both the eyes. If any abnormality is detected during this torchlight examination, then the infant should be sent to eye specialist at the earliest. This test, torchlight examination, can detect many common eye problems in the newborns, and so it is something which can be done, but it is not normally done. Now, the more important test is the red glow test. Now, the red glow test, it helps in detecting a few more common eye diseases and more serious diseases in these babies. After the torchlight is done, put 1 drop of 1% tropicamide eye drops 2 times in the eyes of the baby, and this should be done 15 minutes before the red glow eye examination is done. This eye drop helps to dilate the pupil safely and sufficiently for the test. Alternatively, if we don't want to put an eye drop, then we can do the red glow test by keeping the baby in a completely dark room for a few minutes. These pupils will dilate in the dark, and then we can get the red glow, but sometimes this may not be sufficient for all babies, and that is why by using the tropicamide eye drops, the test becomes more easy to do. To check whether there is a red glow in the pupil or not, one can use either a digital camera or take a close-up photo of the eye, or more commonly what we like to use is a direct ophthalmoscope that all doctors use to check eyes of patients. A normal eye on photography and on ophthalmoscopy will show that the center of the pupil has a bright orange-red glow, which you also sometimes see in bad photographs, that a red color comes in the red eye. If there are abnormalities of this red glow, then it may look white, which is called leukocoria, or yellow, or no glow. If the glow is different in 2 eyes, that is also abnormal. In such a case, the pediatric eye specialist or the special eye specialist should be consulted at the very earliest, because these are serious eye problems. Now, while these tests that I have described will be able to detect any visible abnormalities.
So I'm stopping here. This is available on YouTube. Further, it talks about ROP and some syndromes and family history. So there was a lot of debate when we had this session. There was a lot of debate about the dark room.
because they said that in the pediatric ward there's no dark room, and if you have 30-40 babies in OPD or ward, how do you take them to the dark room one by one and then do the test? So we suggested that is why we suggested that you can put a drop of tropicamide, because these children don't get angle closure glaucoma, and it can be done on the bedside in the OPD. So we said you really don't need that logistics of dark room. But if in some country there may be legal issues of who is putting the eye drop and why you putting the eye drop, or parents don't give consent to put an eye drop to dilate the pupil, then you can do it in the dark room. Otherwise normally they can dilate. So they also wanted to know, will you give some specification for the direct ophthalmoscope? So we had a lot of debate, like what specification for direct ophthalmoscope? We said just any direct ophthalmoscope, small one, big one. We don't think there's need, even local made. You don't have to buy foreign direct ophthalmoscope. We said we don't want to put any specification. Any decent direct ophthalmoscope which is in the market can be used.
Thank you. Thank you, madam.
Very good initiative, madam. And it's quite educative also. Thank you.
So we hope this will make a difference on the ground.
And
as and when it is rolled out, I will keep all of you informed, so that at least in your own states you can watch what they are doing and whether they are doing, and if they need some training from any of you or your departments, then you are able to collect them and provide the training for the simple examinations.
Right. Thank you, madam. Really, this is a
universal screening of newborn. Now we have got another program in universal hearing checkup of all the newborn.
Yes.
If both these are combined.
Yes. That flow they will decide.
Yeah.
The idea is that they were doing all the tests, but they were not doing ideal.
Comprehensive
exactly.
checkup. Comprehensive checkup. Checkup, health checkup.
Yeah. Thank you, madam. Thank you. This is a very good new concept of new eye-borne eye checkup. We should also made it mandatory, as all the gynecologists, whenever there is labor, they have made it mandatory for every pediatrician. They used to stand nearby the labor room and they immediately see the child, whether breathing or not properly, aspirated or not, like that. So we should also make this is an addition to once the baby is born. So the universal eye health checkup should also be added over that. So very good concept, madam. Thank you very much. Thank you. And now our the next speaker is Dr. Purban Ganguly. Purban Ganguly, he will speak on the loopholes and lacunae in RV management, a 5 years retrospective clinical audit. Dr. Ganguly.
Dr. Purban Ganguly is the young, energetic Acoinian. He is the assistant professor of Regional Institute of Ophthalmology, Kolkata.
Thank you, sir. I would like to thank Acoin for giving me this opportunity. Now, in this is a kind of my own journey with retinoblastoma that we have seen in Aioc, Kolkata. When I was a PG resident doing PG MS ophthalmology under the mentorship of Professor Samantu in Bardhaman Medical College, then retinoblastoma existed in books and in papers, and we used to write answers about retinoblastoma in the answer sheets and get good marks in the examination. But when I joined Aioc, Kolkata as a clinical tutor in the division of orbit and oculoplasty and ocular oncology, then every week we used to get these kinds of advanced orbital retinoblastoma, at least 3 to 4 every week. And eventually these children used to die. These things, they save the vision, save the eye, save the life, did not match, because most of them used to come in this advanced stage and ultimately they used to die. These presentations of retinoblastoma, the other presentations other than leukocoria also did not match, because 90% presented at primary or secondary orbital retinoblastoma. When we thought that something needs to be done about it, because this is the tertiary referral center, and why will these children will die? With parental ignorance, the parent did not give us history of when the eye started swelling up so long. Financial problem, Then referral mess. When we used to tell them go to the oncology, get a CSF done, get a blood test done, they were like, we have brought the child to you. That is more than enough. Now you do whatever you can do. And ophthalmology department did not have any kind of infrastructure to deal with this. Ignorance of the ophthalmologists ourselves also, that white pupillary reflex being treated as cataract, operated, eviscerated, then coming as primary orbital, secondary orbital retinoblastoma. And apathy from most of the corners. These children were just left to die in the eye wards, and we used to write the death certificates. So this was the statement between 2017 to 2019. 98% children were referred from elsewhere. 94% of the parents said they did not notice any kind of ocular abnormality in their child. Suddenly this swelling has happened out of some kind of divine intervention. 92% could not give proper duration of the history. 95% patients did not know that this is potentially life-threatening and the child will eventually die. 98% patients with orbital retinoblastoma had the expectation that, oh, I have brought you to a very good government hospital and you do the surgery and my child will be okay. And among the 10% of the orbital RV which were secondary orbital, the patient has undergone some kind of ocular surgery due to misdiagnosis, which has actually spread the retinoblastoma. And 90% required pediatric ICU backup, which was not there. So there were some missing links. And this is the case of a child that I would like to highlight. This child had come from an Adivasi background, and ultimately the child got DORB. We had their contact number. When we tried to contact them, we found out the truth that a child has been killed by their own parents because they could not bear the pain. So with this 90% mortality rate, we thought that something needs to be done. The first thing that we required is the intersectoral coordination between the departments. Everything is there in Medical College Kolkata. Only the problem is that one department, ophthalmology, is not linked with the pediatric oncology department and pediatrics. RB awareness among non-ophthalmological fraternity. There is no awareness among non-ophthalmologists that there is an ocular oncology which is potentially life-threatening, and in a developed world, 100% of the retinoblastoma child are surviving, and in the underdeveloped world, more than 30% of these children are dying. Nutritional support, community tracking, and RB parents group support. So we came across West Bengal government has already a MOU with this Can Kids, which is a NGO organization. They provide with people to support these cancer patients, and we came across the Indian Pediatric Ocular Oncology Group, where there is a retinoblastoma study is going on throughout in the Indian subcontinent. With these two backup, we went to the Director of Health Services and Director of Medical Education, Government of West Bengal. Believe me, we had to tell them that no, you don't have to spend a single penny. You are providing with the chemotherapy free of cost, radiotherapy free of cost. We have making a MOU with this NGO who will provide people who will take care of these children, who will provide a daycare shelter for them, provide nutrition. Then we came across, with the help of this RB awareness group in every health district, 1 or 2 ophthalmologists who are interested. We have formed an RB awareness group so that they could be any white reflex, they could be catched early. Awareness among oncologists, this is a very important thing. Awareness among oncologists that chemotherapy in retinoblastoma children has to be given without tissue diagnosis. Once we send these retinoblastoma children to the oncology, the first thing they used to say is that, give me a tissue biopsy. But when you are touching this, it's like the Rakto Bij. When you are touching these children for a tissue biopsy, it is actually progressing. So that awareness is now there. They are providing chemotherapy without a tissue diagnosis. This is very important. RB patient support group. We have formed groups with the parents that, no, you are not alone. There are people like you. And you believe me, it is providing wonderful result. night shelter for the daycare chemotherapy. One of the most important cause of dropout was the chemotherapy centers are daycare, and these children are coming from very far away. So they have got no place. They used to sit in front of the footpath in the hospital, and that was the principal reason of dropping out. Regular nutritional backup. Only chemotherapy and radiation does not treat cancer. The children need to have food and genetic tracking and counseling. The first thing, this is the awareness processions that we started on a regular basis in the hospital itself to make the other people aware that retinoblastoma exists and it is potentially killing people. Secondly, this person is our resource person, Amina Khatun. She herself is a cancer survivor. She is the one point contact person. When a retinoblastoma gets admitted, we just send him to her. He takes care of them. He tracks them at home. He provides them with nutritional support, regular follow-up of the parents, and this is providing good result. You won't believe, this is the parent support group. These mothers used to stand behind their husbands, not speaking a word and only observing what is happening with my child. Now, when the parent support group is there, when they are talking with other mothers, they are coming in front and they are making a social change. These mothers are going back to their villages and telling others that no, this kind of problem exists. See, I have gone through this. You should not go through this. You contact with Amina. Amina will do everything to you. You come to this hospital. This hospital can provide you with a proper care. So these quasi-educated, half-educated, mostly non-educated mothers are doing wonderful social change for retinoblastoma just by talking among themselves. And this is the wind of the change. You see, we bring them together. The children, they are also coming together. The older one is telling the smaller one that no, this kind of chemotherapy will give you this kind of pain, but you believe me, after that you will be like me, or your one eye has gone but the other eye is there, you can see, or your both eyes have gone but your life has not ended. These children are interacting among themselves. So this was like a slide in a presentation, the saving the life to saving the eye. Believe me, this leap is very, very difficult. We are now going in Aioc, Kolkata, from saving the life to saving the eye. We are proceeding towards brachytherapy because early cases are now coming. Previously, the cases we used to come, it was absolutely hopeless and lost. So we have achieved this. From diagnosis to first dose of chemotherapy has come down to 2.9 days. Within 3 days, we are providing them with chemotherapy. All investigation done. Enucleation rate has come down to below 20%. We want to make it 0. And the treatment dropout rate is less than 5%. Mortality rate, which was more than 50% between 2017 to 2019, has now come down. Even with the COVID pandemic in force, has come down to less than 5%. We want to make it 0. Because in advanced countries, retinoblastoma mortality is 0. So this is the change, as Roosevelt has said, that let our hope and not the hurt shape our future. You see, these children are interacting among themselves. They are feeling that life is there for them. Only apathy was there previously. And in the words of Swamiji, take up an idea, devote yourself, struggle in patience, and the sun will rise. So this is the child who is bilaterally blind, but see the smile and in her face that she knows that she will live. So with this, I would like to thank everyone.
So many
from me. See here, the most important point is counseling the parents. You counsel the parents, encourage them, say this is very eminently treatable. Bring the child back. Bring the child back. Because parents are dejected, disheartened. So that is the most important. It's the parent who has to bring the child to you. So that is most important.
I just wanted to add one more point. I think I'm so impressed because it just shows that, see, a doctor cannot do the whole thing.
Exactly.
That's what he was showing. Doctors are there, but they have only limited time. They have to do surgery, they have to do healthcare, they have to do classes, they have to do research. So what you have shown is that outsource the work. Build a team. Build that health worker, build the parental group, build the liaison with other departments, and if you do that, then the whole microcosm will work towards, as you said, the light will come. Okay, so one passionate worker has thought what is the problem, what are the gaps, why we are not able to do it, and only counseling is not going to solve your problem. You are already counseling. But once he built that ecosystem and the team, and then divulge the work, and then be the leader and watch that everybody is doing audit the work, but then the board starts rolling. Great, great job.
Thank you, ma'am.
See, the problem with retinoblastoma is that it is 75% neonatal and 24% chronic. It is a multicentric focus of tumor. It is not the question that you have a tumor in one eye is extending. So when you have a retinoblastoma, the thing is that you don't have to examine only that eye. You have to examine under the dilatation of the other eye. The problem is that you do confuse because with the leukocoria, there are a lot of conditions which lead to this, like conjugal cataract, retinoblastoma, perceptually membrane, ROP, toxopora, so many conditions. So the ophthalmologist should know what are the conditions which are the cause of this thing. When I was at initial stage, I have missed. You miss by mistakes. I was a right staff, and patient was going to college. I was a pediatrics to me, and I diagnosed it as a congenital cataract. But something came to me. I rushed to the clinic hospital and told, no, I have made a mistake. It's not a congenital cataract, blastoma, so it has to be done on this thing. And well, there are a lot of modalities: enucleation, exenteration, chemotherapy, guide therapy, light coagulation, photocoagulation, so many modalities of treatment there for this thing. But I should congratulate this young man for an excellent presentation. One should all knows that my mentor was my dad. I have this thing, who was a legend of ophthalmology and ENT Kashmir by the name of Dr. Glanvisa Posga, who had done more of a community ophthalmology. In 50s, 60s, he used to go to leper hospitals, operate in boats, houses, without money. That time, nobody used to go to a leper hospital, but he used to go. Even today, I can't reach this. He was my mentor, my teacher for 20 years. Even today, I get the prescriptions of my dad, which are 1970, 1965. A great man, because he was later trained. Initial teachers were this Venkata Swami in local family hospital, and Karan Murthy was a registrar. Later on, he was deputed to Vienna for years, and his teacher was one of the most prominent ones in the world, Professor Black, under whom he did diploma ophthalmics and surgery. And maybe I will not waste my time, and I have a time I can speak.
Sir, thank you, sir. Thank you. Now, our next speaker is Dr. Ashwani Kumar, the rehabilitation of visual handicapped in Bihar. I will request Mr. Ashwani.
Soman.
Ashwani is here.
Ashwani.
Please. Your presentation is ready or not? Ready, na? Please come.
Only one thing to mention. Let us congratulate Dr. Purban Ganguly, the presenter just now on retinoblastoma, for his extraordinary presentation. One thing I like to recall, in the year 2016-17, Dr. Purban, when he was a postgraduate student, he has been awarded with our Acoin Student Scholar Award with 25,000 rupees for research work on community eye health. And he has done a beautiful research work on the rice mill workers in Barwan district at that time, and it was published at that time. Thank you, Purban, to carry on these activities.
अगर बैठ के इनको पढ़ना है तो डॉक्टर साहब को डॉक्टर साहब, if you want to sit, you can sit here.
I can speak. If I can come here, sir, then I can do, sir. I want to.
Yeah, whichever is comfortable, you just sit.
Not comfortable, sir, but I want to.
No, if you sit there, if you are more comfortable, I think he should sit. Somen, chair दो. वहीं पे chair लगी.
We can sit here and speak through this. Yeah.
Up to here, next slide. Okay, I will.
Sir, Dr. Ganguly, यहाँ पे आओगे ना यहाँ. You can use this mic also.
You can see the screen, so you can present.
Yeah, ठीक है. उनको सोमेन, उनको यहाँ ले आओ. Please come.
आप उधर से आ जाइए।
Please come. Sit here.
थोड़ी दिक्कत है सर।
No, अरे no problem, no.
यहाँ पे बैठ सकते हैं सर।
यहाँ बैठिए ना, क्यों नहीं?
सर उसमें अंदर घुस नहीं पाएंगे।
अच्छा, यहीं बैठिए, यहीं बैठिए. We will bring this.
ठीक है सर।
Now this is okay?
Yes sir, thank you.
Yeah, presentation start.
Yes, yes.
Start presentation.
So I am Dr. Ashwini Kumar. I am from Mahavir Nethralaya. 13 years back, I was the best eye surgeon there.
Okay.
But a brain hemorrhage made me paralyzed.
Oh.
So I couldn't work. My left side is paralyzed.
Oh.
So with one hand, I couldn't operate.
Okay.
So with sobbing, I went to Shankar Nethralaya, Chennai.
Okay.
There I learned a new technique of visual rehabilitation.
Okay.
So that I can do with one hand.
Oh, wonderful.
Because I was just almost losing the job because hospital won't keep me for anything because I had no patient. So I learned it from Shankar Nethralaya, Chennai. I went there alone for 1 month training. Thereafter learned from LV Prasad also. There Pradeep Bagga was there, must be knowing. So he taught me lots of things.
Very
Deepak Bagga, right? Deepak.
Very
So
good.
right now I will start my presentation. Pointer is there.
No, you can
Will
just
change the slide?
Yes, next change. Yeah, Somen, you stand there and go and change it. You will do. Okay, thank you.
You can see this is one patient. He had coloboma of eye. You can see his eyes. So for near, I gave him the illuminated handheld magnifier. It has illuminated hand magnifier, means it had inbuilt light. The next one is, it was one video was there. Will it run? No.
Run the video.
Run the video. Just a small video is there.
Yeah, no problem.
If it's run good. अलग से भी उन्होंने डाला था, अश्विनी कौर में डाली थी।
How many speakers more?
Only sir.
Okay, it's not running now. So no problem.
Sir.
I'll just speak. The video is not running, very sorry.
Okay, no problem.
So the low vision, as you know, is the term to use to describe the significant visual impairment that can't be corrected with glasses, contact lenses, medication, or even eye surgery. It includes loss of best corrected visual acuity. Best corrected visual acuity was worse than 20/7 in better eye. And there was significant visual field loss and tunnel vision. That was lack of vision in the periphery, and blind spots are examples of visual field loss. So disability statistics from American survey shows that 2.3% of individuals ages 16 over have a disability or low vision. Next one. So the place was Mahavir Nethralaya, Patna. You can see there were very less patients because at that time nobody knew about the visual rehabilitation. So I had very less patients. So the period was December 2018 to March 2019. I did the complete history of the patient, clinical examination and lab investigations. The investigations were visual acuity, Snellen's chart for the distance, near vision chart, color vision with Ishihara, and ocular movements as well. There was slit lamp movement, not to forget. Next slide, sir. The spatial interest, as you can see, this is my room. When you enter my room, you will see this board that the patient will get a feel that they are at the right place. So the newer instruments like monocular and binocular telescope for the distance vision, and for near, I use handheld magnifier, and then illuminated and non-illuminated pocket magnifiers, dome magnifier, half eyes cutaway. Treatment was different kind of magnifiers were given for the visual correction and improvement. And M training, this is very important. M training means you make big M with rotating your neck so that you can see the periphery. It's for the tunnel vision patient. You can make a big M so that you can see. The next one is the Notex to recognize currency. It's a sheet of paper, sheet of cardboard. It has corrugations and cut marks. So the blind person will feel the cut mark and he remember the denomination. Then he can see that the problems identified were 3 had retinitis pigmentosa, 1 had coloboma, 4 had nystagmus, 6 had Stargardt disease, and 4 had corneal opacity. Diabetic retinopathy has 4, amblyopia was 1 patient, and central CS retinopathy has 4. Next slide. The result you can see from PL/PR to 6/16, 8 patients, and counting fingers of 6/16, 6 patients, and from counting fingers 6/36 in 3 patients. 6/66, 36, 9 patients. There were no improvement in 4 patients. We had total 36 patients. Most patients were satisfied. Now, what was the improvement in quality of life? First one was reading newspaper. Second was doing home and office work. and the child was able to read blackboard and give exams, improvement in walking and independent through M training, handling money, improvement in household and cooking course. Like I go to the home also to train the people how to make the rotis. Like they can't make the rotis with one hand magnifier. So I go their home, I change the light source. I tell them to use the special utensils with them. So I'll change the source of lighting also. So these things I have been doing. Next one is, so this I can see this is a different types of ways I can do this. And these magnifiers are not for the whole life, because after 6 or 7 months, with some brain adaptation, they will see much better. Not 100%, but they will feel better.
Very nice.
So, sir, this was my presentation. Thank you so much. I asked
Thank you.
Dada for my better future, because he has been.
Thank you.
I remember his one thing, Dada. I had my first conference at LV Prasad Bhubaneswar. I was shaking, Dada की करे जाबो हम कैसे जाएंगे अकेले? He is अश्विनी हारा वही है जो लड़ा नहीं.
Wow.
And I remembered that, Dada. That gave me the
Right. Thank you. Thank you, Dr. Ashwani.
Thank you.
Great social work.
We should.
In Trivandrum, we have a Pinurjyoti program where we give free training, vocational training, so that they can do their job on their own and make money.
Oh, wonderful.
They're all free.
Very
All
nice.
free. We are getting the donations from the church, temples, so many organizations.
At Trivandrum only.
They're in Trivandrum. They are attached to the Aioc.
Okay. Very nice.
I started some 3-4 years ago. My own classmate, Dr. Girija, we started it. Then I took over. We have got a good team.
Right.
And we hunt, we recruit, go do field work and recruit contributions.
Right.
To give them free of cost training on these jobs.
Very nice. Thank you, sir, Mahadevan sir, for special comment, and I thank you, Dr. Ashwani, from heart of my core, because as we all know, once a people become little handicapped, he becomes so much nervous. We have seen so many people to committed suicide also. Even they have had lost their vision or some paralysis also. But we should always learn from Dr. Ashwani Kumar. He courage to overcome that crisis. He had a brain hemorrhage, then he had paralysis, but उन्होंने हार नहीं माना. तो this is we should learn these things, and what Dr. Mahadevan is doing, that is also very encouraging. He is providing the
Actually, our own trainers,
rehabilitation.
that we employ them, they are partially sighted.
Yeah.
So I just want.
So ये कहा गया है, हमारे एल्डर्स बुजुर्गों ने कहा है कि ईश्वर आप मंदिर मस्जिद या गुरुद्वारे में ही न ढूंढो, ईश्वर हर इंसान के अंदर विद्यमान है. If we can serve the person, we are serving that supreme power. With these words, thank you very much. Thank you.
I just want to say one thing, sir.
Yeah.
God has given me second life.
Right.
Because I was almost dead. So, and lots of people like Mahavir Netrala, even the झाड़ू देने वाला, he gave the money कि अश्विनी सर को बचाना है. So all the people, they gave me the money. Doctors, they collected the money. So now I have the social responsibility कि now I can give back something. So
Very
I'm
nice.
doing this, sir.
Thank you. Give a big hand. Give a big hand. Yeah.
Another initiative of ophthalmology, it was only at a rheumatoid arthritis. It was a lecture on Gurmukh Private Hospital that was doing 2 hours. My dad used to say that this curve as used to go down.
Okay, sir, we are running shortage of time. Sorry to excuse me. Shraman, now I will request our last speaker, Dr. Ahmad sir. He is from Kashmir, Jammu Kashmir, and he is most dynamic person. And even at this age also, he is very dedicated for the social services. He learned this dedication from his father, and I request Dr. Ahmad sir to deliver in lecture. As we are running short of time, sir, so I will request you 5 minutes, because we have to vacate this hall for the next session. Oh no, 5 minutes we can take, sir. Thank you, sir. Thank you.
ये जो करना है कहाँ से करना है?
ऊपर नीचे respected Dr. Dada and the respected senior colleagues on the dais. I have gone this. First of all, I would dedicate my talk to my dad, agent in J Kashmir in the field of ophthalmology and ENT. At that time, the eye and ENT was combined, and probably there are two stalwarts, probably in India, who are a qualified eye and ENT. And my dad's senior colleague was Professor Dr. Harbhajan Singh. He was DOMS Diallo, and my dad at that time was only DOMS, and he was only eye specialist, and then he learned the ENT from his. And my dad was always telling you should call him Sardar Sahab, and that was the kind of a respect which we had done at that time. And Sardar Sahab was telling my dad, Master. Later on, my dad was went to the University of Vienna, one of the most prestigious institution of eye, ENT, and other modalities, and he worked under there and did DOMS Diallo. So I will start with the talk. It is a houseboat. It's a model of the Dal Lake. This is the hospital where I work. I have a small clinic there. This is This is my dad on the left side, and the center is Professor Dr. Pellet, under whom he did DOMS. Professor Dr. Pellet is one of the pioneer ophthalmologists of the world. He's the first one to detect the nodules of leprosy, which are called as Pellet's nodules of leprosy. The other brilliant ophthalmologists of the world in Vienna are Putscheredopathy, Goldhaar syndrome, Krukenberg, known for pigmentary glaucoma, Fuchs, corneal dystrophy from Fuchs, and now this is, I don't want to just sort of bore you with my topic, this profile. Okay, my topic, which was given to me, was basically from the Dada, was the theme of the, and I have chosen the scenario of the cataract. Cataract is one of the commonest ocular conditions, which is so common throughout the universe. It's one of the most common conditions which everybody has done. It's one of the most common conditions which ensures a kind of a preventable blindness. It's one of the most commonest conditions which has got basically a backlog. We have got a lot of backlog of cataract, and that is especially kind of to be helped in the rural areas by the kind of the community ophthalmology. They are poor. They cannot come, and we have to reach to them and do the surgery. Now, if you go to the past, decades back, when there was no medicine, no surgery, it was by Hakims, Vads, pseudosurgeons. Cataract, which was done, was by a kind of a couching. They were called couchers. What they would do, they would put a needle on the limbus and just look at the lens, and some time the people in the area would become color, and they were happy. They were very happy. Later on in 60s, 70s came the technique, which probably maybe my senior colleagues might have done, was by Van Griffith's cataract knife with Aroga's forceps. You would make 180 degrees incision and put this Aroga behind the iris, catch this capsule at 6 o'clock, because it was thought to be there thick. With the movements, you would remove the lens. Sometimes you may not put stitch initially, put a conjunctival flap, later on stitch put. Patient was admitted for about 4 to 5 days. You would look for the complications like the wound was in position, iris prolapse, and stuff like that. Patient was admitted 5-6 days, discharge. After 15 days, you would give. Later on, the other techniques which were done was Smithinian technique. Indian was Mansingh Nirankari, and Smith was Colonel Smith. The tumbling, that was called tumbling. The other method was Dasur's Aristophac, by vacuum would remove Vectus, syringe. Later on came cryo. Later on came the anti-tumor IOLs, Ben Cross. A lot of anti-tumor IOLs were done by Professor Daljit Singh. He would do in one day about 60 to 70. Later on, because of the endothelial touch, came Suman's cataract surgery with posterior chamber. Later came phaco.
Sir, kindly finish your talk, sir.
Finished. So at present, you have now the latest modalities like you have got phaco with foldable, LENSR, laser assisted. Thank you very much.
Thank you, Dr. Rama sir. With these, I will ask Professor Vasist sir to give the concluding remarks of this session.
So, Acoin is taking leadership for this prevention of many ophthalmic diseases, and Madam has given the main rule and the model, and we should follow and do a comprehensive eye checkup of the children, and do works in the periphery also to bring the eye cases to the hospitals. And Acoin is doing a commendable job and taking the leadership. Thank you.
One more announcement before we disperse. Our National Acoin Conference is going to be held in Bilaspur, Chhattisgarh on the month of September 22, 22nd, 23rd and 24th. And I request all of you to register. Online registration is available in our this Acoin website. And this is, we are happy to announce how many registered. Our Dada Secretary, Professor Samanta, will tell.
We are expecting an assembly of around 2,000 delegates in Bilaspur, and ever record by now only 100 delegates from Nepal has registered for Bilaspur. And never in any Indian conference so much so Nepali ophthalmologists came. Out of 300 Nepali ophthalmologists, 100 have so far registered, and we are expecting more than 250 delegates from Bangladesh. So also from Nepal, Bhutan, Sri Lanka, Maldives, and all other places, around 15 to 20 countries, people will come to Bilaspur. So please do come to Bilaspur, and it will be an ever remembering International Assembly of Community Ophthalmologists. And there will be a 3-hour long session under the captaincy of Dr. Subhadra Jalali Madam on how to check up the eyes of the children and to look after the eyes of the children. So also the public health eye health ophthalmology will look after in another 3-hour session by Professor Praveen Vasist, and Dr. Lakesh Madaria will go on with the diabetic blindness program for 3 hours. So also phaco program by Dr. Shatangshu Mathur. Dr. Harmons Lal will be present there, and this time Padma Shri Dr. Gulapulli Narayan Rao will be offered the Guru Pranam. That's why please do join in this excellent international assembly.
Thank you. I will respect the speaker to please come in the dais so we can have a photograph, please.